Welcome to our Biomedical Informatics and Data Science Grand Rounds. This is our third lecture of this year's series. I'm Paul Naji, and it's really a privilege to be here today. I wanted to share with you before we get started on the Grand Rounds that next Thursday at 1 p.m., November 18th, we're going to have an open house. For anyone who's interested in our graduate programs, we have an online applied master's, we have on-campus research master's, as well as a PhD program. The PhD program applications are due by January 15th, and the master's programs, our application date is due by March 15th. And so we wanted to start our open house series, and we are going to also we're going to share with you our programs, our hands-on exercises that we do with our students and the practicums that they do, as well as we're going to bring some alumni and have you available to chat with and talk about their experiences and how to get the most out of the program. So I encourage you, if you're interested in taking your career to the next level, to join us next Thursday for our open house. And now it gives me a lot of pleasure to introduce our Grand Round speaker for this month as Dr. Julia Skapik. So Julia is the Medical Director for Informatics for the National Alliance of Community Health Centers and a board-certified internist. We also have the great pleasure of having Julia serve on the External Advisory Board for our Biomedical Informatics and Data Science program here for our training program. She is a leader in HIT standards development through her work as a director on the board of HL7. She is the Chief Medical Informatics Officer for Logica Health, which addresses gaps in common data definitions, governance, and HIT frameworks that limit interoperability. And she came to NAC after serving as a Chief Health Information Officer for Cognitive Medical Systems, where she supported federal and private healthcare efforts in military health, care coordination, and clinical quality improvement. During her time as the Senior Medical Informatics Officer at the ONC, Dr. Skapik worked to foster broad HIT stakeholder coordination and engagement, standards development, terminology, ONC certification, and electronic clinical quality measures, and clinical decision support development. She is currently a practicing community health primary care physician with Neighborhood Health of Virginia. Dr. Skapik, thank you so much for joining us today.
Thanks so much for having us. It's my pleasure to be here today as a JHU SOM and Bloomberg School of Public Health alumna. I wanted to talk today about FHIR, Fast Healthcare Interoperability Resources, but I have a bit of an atypical presentation in that I'm not here to teach you about FHIR, what it is, but rather to teach you about the context around FHIR, both from the regulatory side of things and from the standards efforts and potential challenges of using FHIR at scale. I don't have any disclosures today. So Paul actually covered much of this in my biography, but this is sort of where my background and my perspective comes from, working for the National Association of Community Health Centers, which advocates for federally qualified health centers, and working in a health center, but also being a former federal employee. Anything I say obviously does not represent the federal government. I no longer work there, but I am a member of the board of HL7 International and HL7 Europe as well. So sort of come from multiple perspectives at this challenge. So policy by definition sort of generates results, but oftentimes they're not exactly the ones that are intended. I'm going to give you sort of a brief meander through some of the policy things that are influencing our use of FHIR and our use of electronic health records. So as many of you know, in 2009, we had the American Recovery and Reinvestment Act, which led to the HITECH Act. The HITECH Act created a program called Meaningful Use that asked clinical organizations to implement electronic health records. There were a number of requirements around which kind of health records those organizations could get in order to meet the requirement. However, unfortunately, the government was building those requirements and the certification program as they were moving through the process of having people purchase records. So one might argue that in the future, we want to build standards, demonstrate their success and test them, and then require them in a regulatory context, which I think we can happily say that FHIR is much more aligned with that kind of process than maybe some of the CCDA requirements in meaningful use. Meaningful use actually had multiple stages. They ended up sort of taking stage 3 of meaningful use and rolling it into the next regulatory program, in part because there was a fair amount of dissatisfaction with users in the field about what they got for the money that they spent on their EHR. As you know, there are many theories and comments that have been made about why EHRs don't necessarily meet user requirements or user needs. I can say probably the regulatory policy piece of it was part of it, and some of that was, health IT developers told me when I was in the government during meaningful use, because they were spending so much time trying to implement requirements they couldn't really see were benefiting users, that limited their investments in usability. I would argue that now that's been proven probably not to be the main limit to usability, but certainly it probably had an impact. In stage 2 of meaningful use, the certification program really went into effect. And that included certification for quality measures and also transitions of care. Those are still requirements that exist today in future programs, and those things are being transitioned to FHIR. So those are 2 of the main use cases that drive a lot of the work in FHIR and the work that EHR vendors still prioritize in their systems regarding FHIR. In 2015, ONC came out with an updated edition of certification. This referenced an updated common clinical data set and a number of data element class requirements. The data element class requirements were usually something like a terminology binding, though, and not something like, here's how we would describe X condition, or here's how we describe X medication. So many people have demonstrated that despite these requirements, it was not enough to generate interoperability because there was a lot of leeway in how we implement those standards. And I think we'll talk about how that issue still raises its ugly head when we move to FHIR. In 2018 or so, CMS implemented a program called MIPS. This was a replacement for meaningful use stage 2. And I call it out just because it was at this point that CMS started to signal a real movement toward payment for value. So you could either say, I'm a traditional fee-for-service provider, and that puts you in the MIPS program, or you could say, I'm a value-based care provider, and that actually changes the way you do reporting. I think it's important just to call that out because the support for value-based care is a critical need that we have, regardless of what standard we're using. And so I think we need to demonstrate that we can do that in FHIR the way that we wanted to do it in the previous version of HL7 Standards. The place we are today is the 21st Century Cures Act. So 21st Century Cures had a lot of different components, but the main one for ONC was still around EHR certification. ONC uses the term health information technology developer instead of EHR because certification applies to products that are not limited to formal electronic health records. There was a movement by HHS to specifically call out pediatrics as an area that needs to be supported by certification criteria. Obviously, the data elements we use even for vital signs in pediatrics are different from those that we use for adults. And one of the themes I'll try to impress upon you in this presentation is without a requirement and a clear set of standards to support specific content areas in medicine and public health, there is not very much movement in the industry to create those shared definitions and to create the functionality that care teams need to provide high quality and value-based care. There was also a requirement to be able to transmit and receive data from certified registries. As you know, registries are a big component of the research and reporting requirements of EHRs. There's also a requirement to penalize organizations engaged in information blocking. The idea here was to identify whether or not either operational constraints at a healthcare organization or at a health IT vendor were limiting interoperability sort of intentionally. Information blocking has really only been begun to be prosecuted in a small handful of cases, and there have not been, really huge penalties yet. But it is sort of something that sort of hangs over the head of healthcare organizations and vendors, and it's something that's the standard is being sort of, or the regulatory policy is being fully implemented now. So organizations like healthcare's and health center controlled networks, which are the HIEs of community health centers, and community health centers themselves are also going to be subject to this. And if you were a startup or a developer, you would probably be considered subject to information blocking penalties and rules if you're moving PHI and PII. It also created the US core data for interoperability. I'll talk about this a couple times from the Common Clinical Dataset for Meaningful Use. It really was not substantially different in version 1, but there is a process to update USCDI. And one of my arguments here is that USCDI can and should act as a growing data dictionary to allow organizations to know that FHIR definitions that they use locally will be able to be both read and written to by other organizations and products. This is the current USCDI version 2, which actually was just released this year. Again, the level of specificity that's in USCDI is still very limited. There are only a handful of elements, mostly in vital signs, that call out sort of a full data model, i.e., this is the LOINC code that describes the observation, and this is the range of values that you may return. This is a big problem, because if we can't expect what the ranges are going to be coming out of, for example, lab values, if we can't expect how people are going to label a specific data element, then we're unlikely to make the same guesses consistently, and that's a major block to interoperability. But USCDI does grow every year, so I encourage folks to get involved in looking at what proposed items are in USCDI and comment, or even to put forth your own content that will become eventually part of the US certification program for health IT vendors. Furthermore, 21st Century Cures talked about two other things, and I'll mention Tefka first. Tefka is a federal effort to improve data sharing by basically creating a framework and a set of agreements that can be used around mostly networks like HIEs to share information. Part of the goal is actually to standardize a bunch of the legal and operational requirements between organizations, because those frequently are barriers even beyond the standards and technical interoperability components. The last and of course most relevant one for this presentation is that in the 2015 edition of certification, ONC said you have to have some API. They didn't say what API. So you can imagine that it was not really super feasible for people to use APIs to exchange information. But in 2021 of this year, FHIR API with US core support in the specific version, I think it's 4.1, is required for payers to allow patient access via applications. And clinical organizations are going to have to fully implement that by October of next year. Now, keep in mind, many of these things are sort of moving targets. The government can't decide not to really enforce requirements, and they can also change requirements. In meaningful use, for example, they had said, our next rule publication will be X, or our next update to the program will be Y, and both of those targets get pushed multiple times. I just wanted to call out that it's also useful to keep an eye on what payment rules look like in the context of standards. It seems a little bit unintuitive, in fact, but some of the work that's driving FHIR forward actually comes from requirements on payers to share information. And if you look at the Da Vinci FHIR Accelerator, you'll see that basically all of the use cases there, I think with the exception of prior authorization, come out of these rules coming out of CMS and HHS. A couple of them include being able to get bulk data so that there's an ability to calculate quality measures. There's a specific patient level quality measure requirement. There's also a requirement that went into effect, I think in 2019, that payers have to be able to create an extract of what the active conditions they're treating and send that to the next payer when the patient goes from one product or one payer's product to another payer's product. So you can imagine you'll talk in your courses about the stack of technical standards that's required to make FHIR work. FHIR alone can't do it, right? We need things like authorization protocols, we need security layers, we need content layers. But keeping an eye also on, what are the financial drivers of these things is pretty important so that you know who's going to implement what that's going to get paid. So I'm going to move into a little sort of intro to what's going on in the FHIR community. I probably don't have to tell most of you some of the basics about FHIR, so I'll sort of breeze through this. As you know, FHIR was designed to make data extraction and exchange easy. It's fundamentally designed as a transport standard. It very successfully allows the use of services. And those of you who are computer engineers and programmers know that it's pretty easy to use, even if you don't have health experience, because it mimics the standards that are used in, the internet, for example. It's open source, which is a really positive move, I think, from the standards community perspective and the government. And it's a little bit of a buzzword, so sometimes you can get people interested in what you're doing just by talking about FHIR. FHIR breaks the world down into resources. This is an example of part of a patient resource. There's a patient resource on the list of resources under the FHIR specification. This obviously continues to change and mature over time. But if you want to break the pieces of information down into these components, that's what's described in the resources page under the standard. There'll be a lot, as I said, of opportunities to add or subtract things if you want to. But I think of the resources really as building blocks, because having a resource like this doesn't help me to provide any healthcare. So we need to take the resources and layer them, build them into something that actually provides functionality. So FHIR thinks of the foundation, sort of the very base part of the standard. And then in level 2, it focuses on some of the implementation and binding pieces. Then it starts to build those things up into the components of how we define people, places, and things in healthcare. Then it says, how do we describe actual clinical things, financial things? And then at level 5, we can actually take all of these foundational components and do reasoning. Reasoning is the thing I'm most interested in, because that's the functionality that I need to help drive care. So understanding FHIR context and content, again, I'm bringing the informaticist perspective because it's really great if we can do the academic exercise of building cool things in FHIR, but if we can't use them, it's really of no use to us. So I'm going to talk about some efforts to use things in FHIR and deploy them in the field. And I think these are probably not a comprehensive set, but maybe a set of important component areas that together would start to make up the different aspects of healthcare as we provide it. So adapting clinical guidelines to the digital age is an effort to take research and evidence-based guidelines and move them into translatable resources that we can deploy in patient care. So largely this is clinical decision support, but it's not really limited to that. And what CPG on FHIR does is break down even the components of the research so that those things are referential within the guideline, that I would see, say, a practice alert in my system, and that would link to actual clickable links, would take me back to what is the research that tells me to do this? Because we should all have healthy skepticism about any intelligence provided us to by the typical EHR, I think, at least at this point. One of the nice things about this too is it helps us to actually maintain and keep these things up to date. If we know that a specific finding has become, conflicted with new evidence, and we have that coded in the CDS, can actually tell the system, show me all of the rules that would be affected by this change in the evidence, so that I can go immediately and make sure that all of them are still aligned with the evidence and the guidelines. I talked about FHIR clinical reasoning. So FHIR clinical reasoning, as its fundamental use case, focuses on clinical quality improvement. Clinical quality improvement is a combination of activities from decision support through measurement. So in the previous version of HL7 standards, clinical decision support and clinical quality measurement were two entirely separate activities, which is a little funny because usually you use the exact same guidelines and recommendations to develop both. And if you're trying to measure how many mammograms you give, for example, one good way of improving your measurement is to prompt users to provide the mammogram at the time that the patient needs it for the patients who need it. So the FHIR standard actually brings those two activities together and says, let's define the required care activities, the right patients at the right time, and we'll both provide decision support and we'll measure whether or not we're adhering to those guidelines. If you build a clinical decision support rule or a measure in FHIR, oftentimes 80% of the content is identical. So in terms of moving clinical guidelines to the bedside, the CPG on FHIR is actually the specification that the Bringing Guidelines to the Digital Age describes those Lego blocks, if you will, of information. And if you want to go in and try to build out a guideline, you can start with CPG on FHIR and then move that through FHIR clinical reasoning. Enabling care coordination is probably a really under-addressed component of our existing healthcare system, but FHIR does offer us the care plan, and I bring this up in part because support for the 4 components of the care plan is already part of USCDI. In I think it was 2015 edition, ONC added health concerns and goals to the Common Clinical Data Set. So there should be a place in every EHR that describes the health concerns and the goals. Interventions are the regular care activities that would be described like medications, procedures, those sorts of things. And then health status evaluation and outcome, those would be how we would measure the success of an intervention. And the thing I most like about Care Plan is that it provides us with an opportunity of how a future documentation for healthcare might be provided. Instead of creating a static note that says, today I did X, devoid of what happened last week and devoid of what's happening in the future, the care plan says, let's talk about this person's diabetes. Last month, the patient's diabetes was in this state. We chose to do X intervention. And today we can update that care plan and make it longitudinal. Obviously, many patients would have multiple care plans. But this allows all the members of a care team working on a problem sort of have a shared workspace. New CMS documentation rules actually remove a lot of the E&M documentation requirements, which theoretically makes this a possibility. And the other thing about Care Plan is that it was designed to also address concerns that aren't necessarily traditional problem list items. So the patient doesn't have housing would be its own care plan and would go into their record along with the rest of the data. I've mentioned the DaVinci FHIR Accelerator, but obviously I'm a big fan. Having payers involved in support for payer data in FHIR is really important because we know there's a lot of missing data. It's very difficult to validate data in healthcare, and using data from the payer to validate and fill in care gaps or data gaps is really a potential use case that we can move to relatively rapidly. CMS already makes a FHIR Medicare data set available to healthcare organizations, and they are working on trying to get that up and running in the Medicaid space as well. But many of the major payers already have support for FHIR in many of these use cases. And prior authorization was one of the very earliest FHIR use cases. It's actually also one of the most successful. Many organizations have moved to doing electronic and automated prior authorizations and been extremely pleased with the results. I encourage you to take a look at DaVinci. I'll say that they also have a really great number of tools, including a good reference implementation that you may be able to piggyback on. Gravity FHIR Accelerator works on social determinants of health. It's largely funded by ONC, but it really is sort of a consortium kind of activity. It came out of the Siren project, if people are familiar with that, The Gravity project sort of has two main arms. One arm is actually focused on terminology. So they're doing these environmental scans, saying what are the definitions out there in a specific domain like transportation and security. And then they request additional codes where coded elements aren't available. And to some extent, I think they're working on making some value sets or at least some crosswalks in the domains that they've covered. The other arm of the Gravity FHIR Accelerator includes an implementation guide in FHIR, and that is already available in an STU, a standard for trial use. That standard currently is focused on sort of the basic use case. Can I get some information about SDOH? Can I send it to someone, maybe with a referral or request for them to do something about it? And can I get that back? This has been tested, I think, in a couple connectathons now. And if people are interested in the social services and SDOH space, this is its home in FHIR. And this is an open accelerator, anyone can participate. MedMorph, I want to call this one out. So there's always a lot of consternation at healthcare organizations about the heavy weight of reporting requirements. There's pretty much a lack of coordination, not only across different CDC divisions, but definitely between the federal government agencies and definitely between states and localities and the federal requirements. There have been a number of organizations pushing for greater harmonization. I think ONC and CDC and others do recognize that this is a big problem. It's not a use case that drives clinical care either, right? It's something that actually weighs down the clinical care enterprise, and it invests resources in activities that aren't improving clinical care. I remember once a children's hospital in Southern Florida said they had less than 200 beds, but they had 6 FTEs that their entire job was to abstract registry data and enter it. This included reporting data. And if someone went on vacation, they couldn't replace them because there were so many specific requirements to each reporting system that they couldn't even have someone fill in. So MedMorph seeks to, at least on the public health reporting side, starting with CDC and the federal agencies that do public health reporting, to align all those use cases and harmonize them. And there is right now a FHIR program or project called ECR Now. You can use ECR Now. There's an application, and we have some health centers actually that are testing this to do all of your mandated reporting to CDC. So I encourage people who are in the public health space to take a look at that. And I'm happy to make a connection between the CDC team. So I'm sort of creating a notional idea here that all of these pieces should really line up and be one coherent piece of work. And I'll just admit that in 2021, that's more notional than reality. There is a lot of excellent collaboration in the FHIR and HL7 space to try and keep each other aware of what is going on in the different areas of work here. And of course, HL7 content gets balloted. The idea that a group of people just reading through each other's ballots is going to lead to real integration, I think probably not true. We need more methods to really make sure that these things work as a coherent whole. I wanted to talk now about some of the pros and cons besides this integration piece in the FHIR space. So FHIR tooling, not all, but a lot of FHIR tooling is actually free. And this is a good thing, I think. I have a list here of some really good resources. Probably many of you are already aware of them. Many of these things can do validation. They can allow you to build profiles. They can allow you to do test cases. They can allow you to build APIs. One of the things you always want to keep an eye on when you're doing testing and building is what version are you in and what version is your tool supporting? And that traditionally has been a problem as FHIR has matured very rapidly in the last 10 years or so. I think, if things are slowing down a bit and people are getting the opportunity to catch up on the versioning side, hopefully that will continue to improve, but something still to keep an eye on. But in the tooling space, there's still a lot of tools that are built sort of for the good of the community. which means that they may not be the #1 priority of the volunteers that are working on them. They may not be totally ready for production, but they put them out there, of course, because we're in an open source community, we're collaborating. And they're often very technical. So if you're a clinician like me and not a computer engineer, it can be challenging to use some of these tools, right? There's a pretty uphill battle to get there. There are some tools that are a little bit more friendly to clinical folks, but I think really what we need in the future is tooling that's so easy for users that a smart clinician who's an expert in, say, lupus nephritis can go in and build a suite of FHIR applications to support patients with lupus nephritis. And we're definitely far off from that. I think I've sort of alluded to this before, but in FHIR, because it's always attempting to accommodate sort of the broadest use case, the international use case, it rarely requires very much metadata in profiles and resources. But that means that you don't know how much metadata is going to be implemented or included in a FHIR message. This really is a big challenge when you try to get data to the point of care in and out of a functional system. And what we see a lot is that it's more feasible to display information to users than it is several orders of magnitude harder to get that information into the system, the native system, right? To get it into the data warehouse, for example. There are also projects in FHIR that have been very ambitious in what they expect a clinician to enter. So sometimes it goes the opposite way, and the clinician is supposed to fill out 10 different pieces of information about a blood pressure in order to meet the profile requirements. So I think a lot more thought about that will happen in the coming decade, but it's something to be aware of, and something that if you work with some end users as you're developing these and some clinical tools, that will help to give you a good sense of where the sweet spot is. FHIR terminology. So I'll start actually by saying that the first time I complained about FHIR terminology at AMIA, I think in 2017, we have come a world forward from there. HL7 has invested a lot in the last few years into FHIR terminology services and FHIR terminology specifications. But the issues of binding and mapping are not easily overcome. So many FHIR profiles are intended for international use, so they may have no terminology bindings at all. And if you're familiar with the international terminology space, you know that's because some entire countries don't have access to SNOMED, et cetera. But it means that there's nothing to create a conformance requirement there. In the US, if you look at US core, there are terminology bindings that are mentioned in all of those federal standards I talked about at the beginning, which help this problem a little bit of terminology bindings. But the constant effort of mapping is really not resolved, and FHIR doesn't, they haven't really cracked the code on supporting translation and alternative binding approaches to make it easier for machine to machine to recognize equivalent concepts and non-equivalent concepts. And I can say just this week, I was in on a presentation by a team that had done some FHIR clinical decision support implementation at Yale. And those folks said that, well, they could find in FHIR in their system, very basic things, a patient resource, but getting information into the system was nearly impossible because of the effort it was to map it to concepts that are already there. So challenges in FHIR clinical engagement. So obviously I'm very passionate about this as an HL7 clinician, constant complainer. The FHIR has been largely driven at the beginning of its development by a really smart and excellent group of developers. And clinicians who have been participating in its use have, often said, hey, wait a minute, what about negation? And they said, well, that's in the 20%. So FHIR operates in the 80-20 principle, which means they're willing to cover the 80% most common use cases. Now, I think over time, obviously, 80-20 principle will fall away. But in the past, people had said, like, well, it's not that important to support negation. And several people said, well, rule out chest pain is very different than chest pain. Now negation is supported in FHIR. And so, as I said, this is sort of an evolving picture. But the most exciting thing is that HL7 is in the process of launching an implementation division, which will have as its goal the increasing engagement clinicians and informaticists and the increasing implementation and real world systems of different parts of the FHIR specification. And eventually multiple parts simultaneously of the FHIR specification, which hopefully will also help us to address our integration challenges. I would suggest for those of you on the line here that participating in FHIR clinical connectathons and participating in this implementation work at HL7 would be very valuable to both the standards community and hopefully yourself. I mentioned integration before. It's almost impossible actually to know how much stuff is out there in FHIR, and that's a little bit of a challenge because even if I am very knowledgeable about wanting to harmonize the content I build, it may be very difficult to do cross-checking. I did point out that the FHIR validator has gotten some good improvements in functionality to test across IGs and profiles, but it's not really supported broadly, and there's no requirements in the balloting process to do that kind of testing and checking. So hopefully that's something the implementation division will tackle very early on. I wanted to call out the use of OMAP. This year, HL7 announced a partnership with the Odyssey project, and of course, I should have defined the OMAP acronym here, which is, Paul, maybe you can unmute and say it.
Oh, you mean the Odyssey, the Outcomes Medical Partnership?
Yeah, well, no, the OMAP data model, what OMAP stands for. I've gotten so used to just saying it.
Yeah, well, Odyssey is the Observational Health Science Data Informatics, and OMAP, I believe, is the Medical Outcomes Partnership. I forget what the first O is.
Yeah. Okay, great. So everyone can Google that, I'm sure, right now, and I will put it in the next version of these slides. But I think the exciting part about it is, while FHIR has, it has a data model which is sort of not designed, but rather by implementation, right? So the entire set of content and resources in FHIR itself becomes a data model, but it doesn't hang on a logical data model. So there's a movement to use OMAP as a logical data model to improve some of the consistency around the representation of clinical concepts. Remember, very early on in FHIR, there were a lot of clinical connectathons where we would say, is this an observation? What is it? So OMAP can help us to address that. And again, the Odyssey community is an open source community. Paul is much more knowledgeable about it than me and much more involved. So I encourage you to ask him and get involved there. So hopefully at the end of this presentation, you will be actually on FHIR. You'll be ready to be on FHIR, FHIR. Just a couple more quick challenges. So this is a challenge everywhere in standards, right? Governance. FHIR isn't a content standard, and they don't endorse content, and they don't provide necessarily oversight of the content, with the exception of, is it conformant to the core, and did it pass through the ballot process? So additional clinical governance mechanisms would probably help to say, this is really good stuff, and this is not so good stuff. So I think that's one of the things that will come out of the implementation division, but just something to be aware of. Just because you find something in FHIR doesn't mean that a group of 10 clinicians or even a group of 10 FHIR developers would be like, yeah, that's really great. It might not have gotten to the point of even passed through 10 hands yet. I already talked about mapping local content, but I can never stop talking about it because I have a team of people who all day long is going through spreadsheets of manually entered data to try and remap it. And that data will never be usable in FHIR at this rate. So I think one of the things that I'm always trying to impress upon people is you're building stuff in FHIR, make sure it is conformant to things like USCDI, look at other content in FHIR, and make sure that whatever you're coding is something that can actually be extracted. I actually encourage people to find someone with real system, if you can, 3 different systems, and say, what does this look like there? And that will help you a great deal to build content that actually can be found in those systems and other systems. Until USCDI or certification or FHIR library or something gets to the place where there's a good library of content that's really well specified, it's going to be really impossible to do plug and play. It's still going to require a developer or an informaticist at the site to sit there and find all of the content and try to remap it. But I'm not here to be, oh, there it is, Observational Medical Outcomes Partnership. But I'm not here to say that FHIR is bad. FHIR is, probably the best standard that we've developed to date. And trying to put all of the limitations I've talked about here onto FHIR is probably not the best approach either. But we do need the implementation division. We need more clinical and usability work. We need more integration testing. We need a data model to get to the place we want to be, where literally people can go to the App Store in their EHR and turn stuff on, or better yet, they can get rid of their EHR and get a lightweight platform, and their whole EHR becomes plug and play, much like your iPhone. So it's not that FHIR isn't good enough. It's that many of the healthcare technology challenges that aren't the technology at all. It's content, it's governance, it's standardization, it's testing. And so I really want to impress upon you that you will run into these problems. There's no way of avoiding them. But if you're aware of them, that will help you have realistic expectations. And hopefully you can be part of the community that works to advocate for improvements that will address those. So, this is where we've been in the past. FHIR's been around for a while now, right? The first DSTU is September 2014. Now we're moving towards widespread adoption of FHIR APIs. We're in the development of our 5 more bells and whistles, better tooling. And this is the future. We're fingers crossed moving towards something that will, free us from the place we've been, which is in many senses not adequately supported by our technology, to a place where we can get whatever we need and we don't have to take anything. So my last request again is for all of you to get involved in the standards community, to reuse the content that's there. And I should have mentioned this, but if you find that the content isn't working for you, please provide that feedback to the owners of that content and see if you can get them to improve that before you make something new. Keep in mind the maintenance of content in standard space is always a challenge, and that includes freely available content. So as you're creating a plan to build something, you should also think about the plan to maintain it. I encourage you to ask others to do QA on your material to validate your workflow and use cases. And if a tool is almost what you need, I encourage you to reach out, because many of the folks in this community really want to see success and they really want their stuff to be used to help patients. Keep in mind that informatics means that people should come before technology. So integrate clinicians, implementers, and even patients if you can on the first day that you start on any development project, so that you have the right personas, the right use cases, the right workflows, the right data flows. Test, test, test. I don't think I have to say that enough, but find that billion-dollar products haven't been adequately tested. So it's probably still worth mentioning. Participate in HL7. There are increasingly a lot of research and funding opportunities. So keep your eye out for that. And if you're as close as you can legally get to a patient, you're doing the right thing. So thank you very much. This is my email. I'm happy to talk to anyone and provide advice. Obviously, as a leader in HL7, one thing I can do is point you to the right person at HL7 who can move your stuff forward.
Julia, thank you so much. That was really an amazing presentation. We have a couple questions, and Harold and I will bring up some of the questions from the audience. I wanted to ask you first, so I wanted to know, what does, I see a lot of people investing a lot of time into FHIR. I see a lot of resources now getting to high levels of maturity of 4 and 5. I feel like, it's becoming, it is certainly, we're seeing a lot of effort into it. What does success look like for FHIR and adoption? Because it doesn't necessarily need to replace HL7 version 2 to be successful. It does different things. And so I'm interested in just trying to get your thoughts on how do you, where do you kind of see where we are in the maturity adoption of FHIR?
Yeah, so that's a great question, Paul. And I probably just totally glossed over the mention of previous HL7, V2, V3 standards. I frequently speak to people all over the industry who are like, why would I do that? I can already do it in V2. And I totally get where people are coming from. It's all about what your use case is, right? Part of the reason the payers are so successful is the sophistication of their use case is low, right? They're used to putting the information on a piece of paper and sending it to someone. The use case in FHIR of sending a virtual piece of paper to someone is quite easy. If we're trying to do very sophisticated things like support patients and decision making in real time, that becomes much more challenging. And it's not even necessarily FHIR itself that's the major roadblock. It's the quality and standardization of data in health records. It's the amount of feedback that people who do data capture and people who use data are already getting. It's the way that we present information. So I think the answer is it depends on who you are. If you're the lab information system vendor who said, why would I do that? I already can use V2, then you don't see any need for FHIR still. If you're the payers, you say, well, this is pretty easy. I can do this at scale. I think I'm in a good place. And I think that's why, the process to get to normative is appropriate, right? Everyone needs a patient. So there is content in FHIR now that is normative. But if we're talking about the complex use cases that really, make me want to go to work in the morning, I think we're still a ways off. But again, Paul, it's not necessarily FHIR's fault. It's that it's not just FHIR. FHIR is an important player in a very large, complex ecosystem. But FHIR can actually help to drive fixes to those problems, because if FHIR is able to say, this is not on me, this is on you guys. If you guys want this use case to work, you have to figure out these content and governance things, then hopefully someone will continue to step up and move that work forward.
I would agree. I think it's going to be the innovator's dilemma of the new niche of clinical decision support tools for providers and for patients, for education, that really require this new type of integration work. But I think that's fantastic. So I have a question from the audience. So information blocking got a lot of attention here last year. And one of the questions are, is it applicable to medical devices as well as IT systems?
So if you look at the regulatory language, it doesn't talk about the context at all. It talks about the activities that you engage in. And if you either create data in a patient care context or store and exchange data for a patient care context, then you're subject to information blocking. So largely that applies to organizations that provide care or organizations that trade information. But in the sense that an application does those things, it could be subject to information blocking.
I see. Not necessarily the source of the information from a device.
Yeah, it would sort of depend on who's declared sort of the agent who's moving the information, right?
Agreed. So do you see a role for third-party tools which operate between FHIR applications and EHRs in order to fill in potential FHIR implementation gaps?
I see a role for that regardless of what the standard is, because if you've ever tried to work with native EHR data, you know that you right now, your whole team are that layer. So if you had a tool that could replace those 6 FTEs, you would want it. It probably can't be more expensive than 6 FTEs. That's usually pretty expensive. And in some places, 6 is not remotely the order of magnitude we're talking about, right?
No, exactly. It's actually much more than that.
Yeah, there are a couple regulatory things that could make some of that stuff easier, Paul. ONC had talked, a decade ago about, should EHR vendors have to share their data dictionaries, or should it be legal for them to not allow organizations that have bought their products to share their data dictionaries? So there, I mentioned the regulatory space, like you keep coming back to it because some of these barriers are possible to break through at multiple layers. But like the vendors could all come together and say, let's just share, but they haven't. I don't see it happening.
Well, I'd like to mention. Harold, do you have a question?
Well, I wanted to kind of build on that question. Each EHR has a little app store, and they seem to be reproducing proprietary notions of apps. And yet, FHIR is supposed to make plug and play. So, can you comment on that tension between?
Yeah, so I've seen some great presentations on folks who actually did the work to reach out to all the vendors and estimate based on the number of calls of an application and based on the vendor, what the cost would be to a developer to make the thing work in the field, or what the cost would be to a healthcare organization. It can be prohibitively expensive. In fact, it is often prohibitively expensive. It's forcing developers sometimes to re-architect the things that they build so that they make fewer calls, because many systems charge based on calls. So that's definitely a consideration and something that you would want to research, I think, if your plan is to build an app and have it available in the App Store. I think also, there may be some regulatory movement on that at some point, because the barrier to entry to the startups and the open source folks is pretty substantial in some cases. And so that's another reason why I think I see this movement towards a lightweight platform as being more likely. I think the HR developers may not be thinking that that's really going to come to fruition. But at some point, you can't afford to buy 10,000 apps. And in fact, I would argue that a large healthcare organization needs at least 100,000 different applications, right? If applications support specific use cases, think about the complexity, the different scope and breadth of clinical medicine and patients and care settings. It may be 1 million. You could never pay $100,000 for each thing. If you need 1 million things, you couldn't even pay $1,000 for each thing, probably. I mean, maybe Hopkins could.
No,
they wouldn't though.
Not even Hopkins. Well.
Okay. And so I'm just wondering, so one of the things that I'm wondering about is, as we do 1 million decision support applications for providers sitting on top of an EMR, a lot of what we see is we need to then have usability guides for make sure that there's consistency in the communication of information. Do you see a role for usability guides within FHIRs, or something that they've already been working on?
So I think right now that information is incorporated where the forethought exists in the implementation guide developers in the implementation guide. Certainly on the policy side, no one has remotely scratched the surface of usability. I actually think in the standards community, more has been done, right? The BPMN work has been looking on how to standardize workflow and how to make it easier to implement a standardized workflow. There has been work in the standards space on usability, but I think it's a ways off. And I think probably in an ideal world, a usability guide would be a component of an implementation guide, and it would be a requirement to ballot something or to sell it. I mean, I really hope that at some point there really is a huge library of profiles and extensions, and you want to build something, you just go in and you say, oh, I want gestational diabetes for patients, in this group, and there they are.
I think you're right. I think one of the interesting things are, I mean, while we do have these app stores now by the EMR vendors, the number of apps that are being adopted by the EMRs is in the tens. It's not in the hundreds or thousands. It's a lot of work to implement each app still. It has not achieved quite the plug and play, and there's still, of course, a lot of training involved with it.
Yeah, I think it's gonna be a back and forth for a while, I think, as it determines how the market works, and then how the vendor platforms and app stores distort that market. It may lead to some interesting changes in what people decide to do 5 or 10 years from now. I mean, I still mostly see people bouncing around to different traditional EHR systems as though that's going to fix their problems. But somehow I doubt it. You just have maybe slightly less bad, same thing.
With you, one of the things that excites me the most about FHIR is clinical reasoning. Where we can put evidence into action. And I find myself, I want to jump over resource adoption so I can get into reasoning. And so how do you see, how can we find those two in balance? Because I mean, the real value is by putting care plans and evidence into action, but we can't do that without having all of the resources underneath it with good, with accurate quality data to be able to do it.
So I think there's kind of a back door here, Paul, right? So CMS has had all of these different regulatory-based quality metrics for a long time. And the ECQM program started in 2012, so it's been almost a decade now. If CMS could possibly be agile enough to modernize the work that we did under ECQMs, then all the data elements in ECQMs could be a single library. They could force harmonization across ECQM developers, make a big library of that stuff, and say to the vendors, you have to support these because these are regulatory measures, and they'll be certified. So if you have any customers who want to use these, then you need to test that you can be conformant to this entire set of FHIR measure/TDS tool. And CMS is aware of that. I mean, they've been aware of it for, maybe 8 years now. In fact, CMS and ONC themselves created FHIR clinical reasoning using their own funding, specifically to support the next generation quality measure use case. I was actually the GTL on that. And I think that was probably one of the greatest investments that's helped to move FHIR forward, at least in the early stages, towards supporting clinical care and not just towards supporting many of the other operational use cases that are much easier. But it's still hard, right?
It is a very active area in the FHIR Odyssey collaboration, the digital quality measures area. I have one last question for you, and that is, one of the challenges is resource profiling, is ensuring that it's going to be specific enough for the evidence you want to apply your evidence to. And so you see the US core that helps constrict the resource. And then we've even seen like QI core, which builds on top of US core to get it even more specific for the use cases. So I guess how much work needs to be done to get it to these usable states? Do you see continued work in resource profiling?
Yeah, absolutely. And I think, what there should be is in both the regulatory program space and the standards, especially the content space, is like a runway, right? Like we build the developmental content, we have people QA it, we do some pilot testing, then we say it's usable for something, then we use it for a little bit, and then we propose it as a provisional element in a required set. And then it matures into the set, much like USCDCI. And then it should be promoted as it's demonstrated that it's needed, usable, and stable all the way up to the FHIR core normal standard, in my opinion, but at least to the US core standard. So I think that actually was the use case of QI core, was to say, how do I take the stuff that's not in US core that I really need to build stuff and make it available somewhere in a coherent set so that then they can push it up to US core after the fact. And I think the same thing is true of, you know, the content and the tooling and all the stuff that's out there. We should just have this expectation that everything is constantly evolving. You push it all the way up to normative, and then until the next better thing comes along, you have that and it's fairly stable.
Great. Well, Julia, thank you so much for your time. It was really a wonderful presentation, and it's really exciting to see this field is really beginning to accelerate, and we're certainly seeing more adoption. So it's fun to watch it grow.
Yeah, I'm really excited, Paul, to see what happens in the next couple of years as vendors and payers say, my FHIR API is ready to use. Because I think it's going to be exciting and also a little bit of pulling your hair out for a while.
Well, I can't wait to start to use them.
Same here.
And with that, we'll close our grand rounds for the day. Everyone have a great afternoon, and we'll see you next month. And I hope you can join us next week for our open house. And you'll see on our LinkedIn page invitations to register for that event. Thank you again. Take care.